So, without further ado, I would like to introduce Dr. Mohammed Abdul-Latif, who's going to talk to us about all we need to know about immunotherapy. He's a consultant clinical oncologist working at Mount Vernon with an interest in urological and gynae cancers. Welcome, Mohammed.
Hi, thanks. Good morning, everyone. Thanks for having me here. Always a pleasure to come back and talk outside of the cancer centre. We're only just next door, so happy to do so. Immunotherapy is becoming increasingly more prevalent. You must be coming across patients now who have either been on it or still on it, even in a palliative context. It sounds mysterious. To some degree, it is a little bit mysterious. I don't even think we know how it works very well. But it does come with a lot of caveats and a lot of issues, and that's probably what I'm going to try and do a bit of myth-busting for today. So I'm a clinical oncologist. I'm based at Mount Vernon. I treat urology and gynaecological cancers, but I do have a specialist interest in brachytherapy, and I use immunotherapy regularly in both palliative and in the curative context. So we'll talk a bit about what it is and how it works, but more importantly, actually, the toxicity element of it. So we want to talk about the side effects associated with immunotherapy, but also the consequences of immunotherapy in terms of the community management of these patients in both primary care, but also in palliative care. So cancer. Our understanding of why cancer happens, how it happens, and how it develops has evolved dramatically over the last decades. Okay, in the year 2000, we had 6 hallmarks of cancer. Things like, avoiding cell death, unlimited proliferation, immortality, things like that. Okay, now we have over 10 individual hallmarks of cancer. They call them. I'm not going to bore you with them. But essentially what you have is cells that are undying. There's unrestricted proliferation of the cancer with genomic instability. And essentially the cancer develops its own angiogenesis, its own vasculature to proliferate itself and grow and develop. But ultimately, the last point is the most important point that we've discovered in the last decade or two, which is immune evasion. The immune system just fails to recognize that there is cancer. Usually, in all of us, if you start to develop cancer, the immune system picks it up quickly and snuffs it out. Something wrong has happened here. And when we talk about immunotherapy, there are multiple classes of immunotherapy. We're going to focus on one today, which is checkpoint inhibition, which is one at the top, and I'll explain what that means in a second. But there are loads of different ways of modulating the immune system to treat cancer. Okay? So cell therapy, which many of you may have heard of as CAR T therapy, means you genetically essentially modify and select for various white blood cells, and you re-inject them back into the patient so that they can target the cancer. That's mostly in hematological cancers. Cytokine therapy is really old. It's very rarely used now, but you use interleukin-2, things like that. Very, very unwell patients used acutely. And now more up and coming are things like vaccines, cancer vaccines. You vaccinate people against the cancers that they have so that their own immune system can treat them. And finally, viral therapy, where you use certain viruses to re-stimulate immune responses, for example, in melanoma. But checkpoint inhibition is the most common one used in solid oncology, which is what we'll talk about. So the way it works is there are brakes on the immune system. Okay, those are in all of us, but particularly in those with cancer, we find that some of them have stronger brakes, which essentially means that the immune system comes, thinks that there's a problem, but then all of a sudden gets reassured. There's no problem here, move on. Okay, checkpoint inhibition works by stopping those brakes, releasing those brakes, so that the immune system is almost activated and is stimulated to try and respond to the problem. Okay. And it works essentially by these different receptor targets, which you can see in this table here. The majority of them are PD-1 or PD-L1, which is the ligand for that receptor antagonists. So the idea is you give them the drug, you block that receptor, you release the brakes, and the immune system essentially wakes up, goes, oh my God, what's going on here, and targets the cancer. Okay? Sounds great, okay? And actually, over the last decade or two, we've had developments in almost every single tumor site. You will find some form of indication for immunotherapy. It's a busy slide for a reason, because I'm trying to illustrate that it's everywhere now. Big pharma has essentially pumped immunotherapy through every indication, palliative, adjuvant, curative, whatever, and they found some sort of benefit, whether it's tangible or not, it's up to debate. But you can use it in the first line or second line, palliative or curative setting for most tumor sites now. But what you will find if you read the small print on this slide is actually the majority of indications are palliative, so you are bound to see these patients in your practice, okay? And actually most of them will fall within a specific subset of tumor sites. For example, melanoma, head and neck cancer, lung cancer, and GI cancer, okay? And there is a reason for that. To summarize what this slide shows, if you see those black lines, they suggest tumor heterogeneity. The higher those lines up are on the graph, the more heterogeneous the tumors are. So what do I mean by heterogeneous? It means they have loads of mutations. They look different. There's loads of different clones inside the tumor. On the very right is melanoma. And then right after that comes lung cancer. Right after that comes GI cancer. Okay? So these are very heterogeneous tumors. It's no surprise that they stimulate the immune system more potently, which is why these are the tumor sites where we have more success using things like immunotherapy. Okay? So tumor heterogeneity is key. So that's essentially how it works. Immunotherapy targets cancers by re-stimulating the immune system, and it works most effectively in tumors where the immune system is most sensitive. And so examples of where we use it, like I said, in all indications, but most commonly, for example, in the adjuvant setting. So after you've removed cancer surgically, you can use pembrolizumab immunotherapy. Or, for example, in the palliative setting in melanoma, which is the most common setting for melanoma, where you get sort of advanced disease. This is incredibly toxic treatment, okay? Combination immunotherapy. 4 cycles, and I'll come to the toxicity in a moment. But you have complete response rates now in metastatic melanoma in up to a third of patients, if not more, okay, with this sort of approach. When before, and you might remember some of you, melanoma was a death sentence within a year, okay? So there is, some weight to this argument of using immune technology in this sort of way. And in lung cancer, you've got radical indications, such as the use of durvalumab, but even palliative indications alongside chemotherapy, for example. Excitingly, over the last few years, we've had new developments in colorectal cancer, where there's a subset of patients who are MMR deficient. That's another test that you can run in addition to the PD-L1, which is what I've mentioned already, okay? These patients are exquisitely sensitive to immune manipulation. So the New England Journal of Medicine publication a few years ago showed that nearly 90%, if not more, of patients on the phase 1 trial had a complete response to induction immunotherapy. These patients had immunotherapy, then had surgery, and when they looked at the surgical sample, there was no cancer left. So very exciting times for this sort of population, okay? And then you have other things on the other side of the spectrum. Mesothelioma, a horrible diagnosis with a horrible prognosis, okay? They've introduced combination immunotherapy with Ipi/Nivo, which is extremely toxic, okay, with a survival benefit of 3 months. I find that very questionable for someone who's managed, I have managed mesothelioma for a while now, but I just think a 3-month survival benefit with incredible toxic drugs, but it is available, and that is what we do with patients now with mesothelioma if they're fit enough. So there are 2 sides to the coin, I think. This is exactly what everyone is aiming for with immunotherapy, the plateau, okay? The first 2 lines, the yellow and the blue, is immunotherapy. Everything else is not immunotherapy, okay? Chemotherapy. You see that survival drops very quickly with everything else, okay? This is in melanoma, all right? But with the yellow and blue line, with immunotherapy, yes, you get some patients dying, but you have a subset of patients that just continue living, okay? And that's what we're trying to achieve, this plateau where you have this stable disease picture where the immune system is keeping the cancer in check, keeps the cancer from growing, and the patients live a long and healthy life. Okay? But at what cost? These patients will then continue on maintenance immunotherapy for many years, potentially. It's expensive stuff. It means regular hospital visits, regular infusions. Okay? We've now switched to subcut nivolumab, which is a brand new thing. We're the first in Europe to do it, where we give nivolumab subcutaneously rather than IV. So that makes it a bit more comfortable, I guess, but now even more expensive. Okay? And at the end, it's toxicity. These are toxic molecules, okay? Not for everyone, but for the patients who get the toxicity, it's horrible. Toxicity, because the immune system is a whole body organism, okay? The toxicity can affect every single tissue type in your body. Anything that you can add the ending itis to, you can see in immunotherapy, okay? So any organ with any form of inflammation. And the reason why this happens is the immune system gets overactivated, it gets confused, and starts attacking your own body. Okay? So you can get an inflammation of virtually anything. And that comes with varying concern, right? So some it's mild and some it's severe. The most common are the ones I've listed here. So skin, you can get a bit of erythema, that's easy. You just put a bit of a steroid cream. If it gets more serious, you'll have to give IV steroids. Thyroiditis, again, very benign. You just monitor it and replace the thyroxine when the thyroid burns out. But things like colitis can be very damaging. Okay? Things like hepatitis can be very damaging. Pneumonitis. And we do see those in patients receiving immunotherapy, particularly combination immunotherapy, so we have to be very careful, okay? But some of the rarer ones are really difficult to pick up. Hypophysitis of the pituitary, cardiomyositis, for example, things like that, okay, are much rarer, and even endocrinopathies are very rare to pick up. And the exact same thing that I mentioned before, which is the plateau. You have a plateau with immunotherapy, okay? That's for the survival, but you also get a plateau with toxicity, okay? So if you do get the toxicity, it's very difficult to get rid of it for the exact same reasons that you have a plateau with survival, because the immune system is still there. It's still fighting your body. It's still dealing with the problem, okay? And you can see from the graph at the bottom left that some of these can take ages to get better, particularly hepatitis. You've got this prolonged hepatitis that needs prolonged treatment, which is essentially high-dose steroids, okay? Some of them are much quicker, like the rash, they get better, or the hypothyroidism, okay? But pneumonitis, hepatitis, very difficult. But the interesting thing is the patients who get the really bad toxicities are the ones that do really well. But there's no surprise, right? It means their immune system's woken up, it's gone crazy, it's fought the cancer, it's fought your lungs by mistake at the same time. And these are patients, for people who have combination immunotherapy, like Ipi/Nivo, up to 70% of them that had to stop because of toxicity had a complete response, okay? So this is a really difficult payoff. You're putting patients through toxic treatments at the hope that you're maybe going to give them a complete response, but those toxicities are quite frightening, okay? So if you give single-agent therapy, however, it's much more tolerable, okay? And that's what we tend to see more often in the palliative setting, okay? And actually, for some lines of treatment, like pembrolizumab in lung cancer, the toxicity profiles are better than even chemotherapy, okay? 1 in 10 will have some form of grade 3 or grade 4 toxicity, which is better than chemotherapy, okay? And 1 in 20 had to stop treatment due to toxicity, okay? But some agents are more toxic than others. The ipilimumab, which we use most likely in melanoma or renal, is 90% of patients will have some form of immune adverse event, okay? So that's a lot. And these patients will be intensively followed, okay? Anyone in an immunotherapy sort of service will be intensively followed. Their blood tests have to be done religiously, including every known blood test, I think, in the panel, because you're looking for everything: pituitary function, liver function, pancreatic function, everything, yes? So you follow up everything very closely, okay? We have the infrastructure to look after these patients. We've got the expertise, we've got the nurses, but also the referral pathways to the DGHs and other hospitals with the experts there to manage these patients. And the management of toxicities, I wouldn't expect you to manage them, but what would be good is if you have patients under your care who've either had immunotherapy in the past or currently having it, whatever, if they're under respite, etc., that if you recognize that this is a potential immune toxicity, this is a really good guide. If you look for the ESMO guidelines online, just write ESMO immunotherapy guidelines. They will guide you through a really nice algorithm for each immunotherapy toxicity and split it into grade and how to manage it, okay? We all use it, okay? And it grades them from grade 1 to 4 and what to do for each grade. Essentially, early assessment is key, because if you pick this thing early, you give them some steroids, you quash it early, and then maybe they might even be able to go back on the immunotherapy with a bit of care in the future, okay? But if it's really late, chances are they're going to have a really bad toxicity, stay in hospital for a very long time, have lots of side effects, and you'll have to take ages trying to bring it back down, okay? Try and see if there's non-immunotherapy causes. If someone has diarrhea, is it chemo, or is it the immunotherapy, or is it something else that they're doing, okay? Because it'll be really harsh to exclude a patient from actually good active treatment if it isn't immunotherapy caused, okay? A multidisciplinary approach is key, okay? Because actually everyone involved with regards to whatever toxicity is, if it's a chest problem, you want the respiratory doctors involved, chest physio, things like that, okay? An early involvement of us, please, as soon as you think there's an immunotherapy toxicity, just drop us an email. We're more than happy to answer. Contact us. There's loads of ways to contact us, and I'll explain how in a moment, okay? And the algorithms are essentially available for on the ESMO sort of to guide you with regards to when to refer and when not to refer, okay? And actually, we'll be making these decisions, but it's not just steroids that we give for these patients, but we give immunosuppressive agents alongside them if we want to spare steroids, etc., just to keep control of the immune system. But really, the key thing that you will probably be involved in is steroid tapering and management of patients with high-dose steroids who have been discharged with some form of immune toxicity with advanced cancer. So let's go through a couple of cases just to sort of illustrate typically what we would go through, okay? So you've got a young lady with metastatic melanoma who's received 3 cycles of ipilimumab, nivolumab. That's the combination toxic immunotherapy that we've experienced. 90% of these patients, if not more, will have some form of immune toxicity before they reach their 4th cycle. Okay? So she contacts the acute oncology service with profuse diarrhea. She's going 10 to 12 times a day. Classically for this, it's worse at night with cramping abdominal pain. Okay? It's uncontrollable. She's tried the Imodium. It's not done anything useful. Okay? AOS very rightly calls them into hospital for urgent assessments. So obvious, it's an immunotherapy talk, so we're talking about colitis here, okay? You don't have to read this. It's just an example of what the ESMO guidelines look like for each inflammatory condition, okay? But essentially, this is a grade 4 colitis. If you look at what they grade it as, that's very serious, potentially life-threatening, okay? Patient has to be admitted for IV steroids, maybe even infliximab. If it doesn't respond to IV steroids, they'll need a CT scan because you want to grade the colitis on the CT scan. They may even need a sigmoidoscopy or colonoscopy to take biopsies. But sometimes the colitis is induced or directed by viral origin rather than just the immunotherapy. And you essentially monitor them after you give them all those treatments, and it can take weeks to get them off the steroids for patients in this position, if not months. Okay. 82-year-old gentleman with an excised melanoma having adjuvant pembro. So this gentleman, you've removed the melanoma and you're giving this as a preventative measure to reduce the recurrence of the melanoma. Okay. These are the cases that make me a bit sad because you're trying to prevent something. There's a risk-benefit ratio, and then something like this happens. He comes in prior to one of his cycles of treatment with a routine blood test, and his ALT, one of the liver enzymes, is 1,400, right? It's sky high. Everyone panics. They admit the patient. The patients, usually with hepatitis, secondary to immune therapy, are asymptomatic initially. They might feel a flu-like illness or a bit tired, okay? But if you leave things as they are, you will really run into trouble with liver failure, okay? And so what you need is, again, this is the theme, it's always IV steroids, IV methylprednisolone, admission, a viral screen, because again, concurrent viruses can cause problems, okay? And actually liver scanning with a liver biopsy to confirm the diagnosis. And usually these patients, if they don't respond, they tend to be really refractory hepatitis. It takes ages to respond to steroids. So they'll need immunomodulatory molecules like MMF or tacrolimus or something like that, or cyclosporin. They might need to go into a liver unit. They might need to have all sorts of things. Catching these early is the key. As soon as you see the ALT rising, you have to ask the question, if it's consistently rising, what are we dealing with here? Are we missing a hepatitis? Okay. And remember what I said, even if patients stop their immunotherapy, their immune system is still active. So these sort of problems can unfortunately happen at any time during the patient's lifetime, during or after immunotherapy. But the key point is they happen mostly at the time or around the time they've received the immunotherapy. So if a patient's had immunotherapy 3 years ago, chances are this is not an immunotherapy toxicity if you've noticed something new. But if it is within 6 months of them having received loads of immunotherapy, you need to start thinking about it. Are we missing something? Would they benefit from some sort of extra treatment? And this is the big problem we face, okay? And we're not very good at dealing with this as oncologists, I think. And that's steroid tapering. You essentially completely obliterate the immune system with high doses of steroid, and then you leave them on high doses of steroid, potentially for months. Because what happens is you try and bring the steroids down slowly, and then all of a sudden the toxicity comes back. And then you bump up the steroids again, then you try other drugs, and you keep going. And the patient might be on steroids, 40, 50 milligrams of prednisolone, potentially for months. And we all know that, yes, they make you go hungry, and they make you feel a bit better sometimes, okay? But all the chronic problems that come with steroids, including poor sleep, bone health, gastric toxicity, okay, muscle wasting, skin thinning, bruising, all these problems can actually be quite bad for the patients. And some patients perforate because their bowels essentially become so thin and so friable as a result of long-term steroids, okay? So you have to be aware that this is a big challenge, okay? And these are the consequences we've just talked about. And we need to be better at counteracting those. So if you recognize someone on high-dose steroids that's slowly tapering and we're essentially failing to do that, okay? Give them some calcium and vitamin D, give them some bisphosphonate if we can, if we try and keep them going for their bone health, things like that, okay? And a PPI if we're worried about ulceration and gastric ulceration. But really, the sad thing is when these patients come off their steroids finally, you find out actually they can never come off their steroids. Because as soon as you stop the prednisolone, they all of a sudden shut down, and that's because their body has basically forgotten how to make steroid, because you've been giving it to them artificially. And these patients then have to go on some form of artificial steroid long-term and get known to the endocrinologists, okay? The other consequence of steroids is the obvious one. You've given them high-dose steroids to shut down the immune system. Now the benefit of the immunotherapy has now been completely nullified. So that's another sad consequence of it, but necessary if you are worried about toxicity. So the vast majority of patients that you will encounter that have been or are on immunotherapy will be known by oncology units or actively followed up by them if they are at least within a certain time period after they've had some immunotherapy, okay? But like I said, there are so many indications now and so many palliative indications for the use of immunotherapy that you will probably encounter them in the community setting or in hospices. So this is more, I think, targeted specifically at GPs and people who manage patients alongside when we manage them. But there are some peculiarities. Again, the evidence base for them are a bit patchy, but there's strong evidence for antibiotic use over your lifetime and the success of your immunotherapy response. If you've used loads of antibiotics or around before that you've used the immunotherapy and after used or during the immunotherapy use, you're less likely to have a good immune response. And the idea is that that's mediated by your gut microbiome. And similarly, chronic use of things like lansoprazole, omeprazole, and PPI can artificially modify your microbiome as well, which may or may not have an impact on immunotherapy response. So the things in red on this slide are how you would approach a patient that you've seen in the community setting with immunotherapy on board, and then you start asking yourself, oh, is there a problem here? Okay? Are they currently on immunotherapy or not? If it's in red, it means you're at a higher risk of a problem with immunotherapy, okay? When was the last dose recent, or was it months ago? Again, if you're recently taking it, you're more at risk. Was it a combination treatment or a single treatment? Combination treatment, very toxic, okay? Was there a previous immune toxicity or not? This is key, okay? If you've had a colitis before, chances are you're gonna have it again, okay? If you've had a colitis before, you're probably gonna get another one as well, if you're unlucky. And have they weaned their steroid doses recently if they've had a toxicity? So, classically, the patient goes, I dropped my prednisolone from 20 to 15 last week, and now my diarrhea is back. Up you go again. And we start weaning it down even slower, okay? And some presentations can be managed with advice in the community. So, if someone calls up the AOS line and says, oh, this has happened, they've got a rash, it's mild, it's just a bit itchy, what do I do? Well, steroid creams, a bit of antihistamine, and we'll see them in clinic sooner, thanks for telling us, kind of thing, okay? Or if they've got mild resurgence of symptoms, we will not be against you just re-escalating steroids, and then we'll see them in clinic as soon as we can, or see them in the day unit as soon as we can. But to be honest with you, as soon as you call the AOS line and say, I think I've got an immune toxicity, I'm worried, we will see them, okay? So don't worry about that, okay? And we're more than happy to discuss these because they can go wrong pretty quickly. These are the resources available to all of you, okay? The Acute Oncology Service hotline, every hospital has their own phone number, should really be happy to take these calls and give advice about who to speak to and who to refer to if there's an issue, okay? Every hospital should have an AOS nurse or a doctor that is 24-hour contactable for advice at any point in time. The CNSs, the patients will have a contact for their CNS, okay? Their CNS will welcome any phone call about their patient regardless. More than happy to sort of give advice about what to do if there's a concern about any sort of immunotherapy the patient is on. And actually, for those of you working within the hospices, the secretaries are an invaluable resource to getting further information, letters, but also they love emailing me for some reason. So they'll just drop me an email, say, so-and-so is called, can you look into it? And I'll be like, fine, yeah, of course, and I'll look into it, okay? So they'll always hand over issues to us, and we'll look into it, so don't worry. And last but not least, the registrar on call, just go through switchboard, ask for the oncology registrar on call. They're a wealth of advice. They'll be able to tell you what to do, where to refer the patient if they're concerned, or what advice or what things to do in the meantime. So a couple of more cases before we round up. So 76-year-old lady with metastatic lung cancer. We stopped the pembrolizumab because of progressive disease. So she's progressed through chemoimmunotherapy, exhausted all treatments, not on any treatment at present. And you're asked to see her because she's got shortness of breath. What are the differentials? And this is the really challenging point, right? You've got someone with lung cancer who's had immunotherapy. They've finished their treatment, so probably very advanced disease. They're at risk of all sorts of things, aren't they? Okay. And you look through the list, and it's huge, all right? The only message I want to come through this is put immunotherapy somewhere in that differential list. It is probably there somewhere, okay? But chances are it is something else for someone like this, right? She's probably got pleural effusion. She's probably got progressive metastatic disease. She's probably got a lobar collapse. She's probably got a pneumonia. She's probably got a cardiac problem because of all the chemo she's had. She might even have a PE, okay? But if nothing seems to fit and nothing makes sense, and you are concerned about an immune toxicity, you worry about pneumonitis, you worry about pericarditis, myocarditis, DCM. Those things are treatable with high-dose steroids. And as soon as that's within the differential, more so or more likely than the others, for example, then you can call us and we can look into it for you. She'll get a CTPA invariably, okay, which will rule out virtually everything on that list, okay? So it's difficult making those judgment calls on the front line without the kit, but that's why we're here, and that's why we look after these patients. Gentleman with metastatic bladder cancer, we stopped his atezolizumab, it's another immunotherapy, about a year ago due to colitis. He's weaning down his steroids. He's in the hospice because he's deteriorating. He's got a poor prognosis of a few short weeks, okay? He's more confused. His urine dip shows blood and protein. He's got poor urine output. I mean, he sounds pretty poor, doesn't he? And the bloods show creatinine of 400, right, with a low sodium and a high potassium. You could ask why did he even have bloods if he's in the hospice in that setting, right? But that's the oncologist speaking here. So what are the differentials? Again, okay, if you're in the hospice, you'd be like, this man's dying, okay? He's probably got hydronephrosis. He's probably got progressive disease in his bladder. He's dying, yes? Correct, yes, that's what's happening here, okay? But if, let's say, he wasn't this end of life, or it wasn't this bad, and he's well, etc., okay? Ask yourself what's happening with this man's creatinine if he hasn't got, for example, a big burden of disease, if he hasn't got cancer in his urinary tracts, it's just metastatic in the lungs, for example. Why has he got a creatinine of 400? Is something else going on? Is this easily reversible with a bit of steroids? For the majority of patients, like you've already identified, this is probably just progressive bladder cancer and the man is dying. But in the individual cases where you don't think this is a renally driven issue, is this an inflammatory issue? You get nephritis, you get an adrenalitis, you get all sorts of problems, okay? And a bit of steroid will at least make him feel better in his final days than sort of having maybe an Addisonian crisis if he's got an adrenalitis, for example, or things like that, where he'll feel really unwell. So in summary, I think if there's any problems on immunotherapy, just call us, okay? Makes life for everyone easier. We might just say, you know what, it's fine. They're in the hospice, they're in their last weeks, maybe give them a bit of dexamethasone and leave them be, okay? Or we get really excited about it and ask the patient to come in and then we review them, okay? If we are worried about immunotoxicity and we want to do something about it, prompt referral, early diagnosis is key, and talking about doing this in the community or doing it as an admission. And then we will essentially do a bunch of inpatient interventions when the patient comes to us to try and see if we can diagnose the problem and reverse it if necessary. Thank you very much. That's my email address. You can contact me if you have any questions.
Thank you very much, and exactly on time. Didn't even have to prompt, so thank you. Lovely talk, thank you.